Hello, thank you for joining me today to discuss the current status of varicella prevention and role of varicella vaccine. My name is Eunhwa Choi, and I'm a pediatric infectious disease specialist from Seoul National University College of Medicine. In this presentation, I'm going to talk about three topics: the epidemiology and clinical features of varicella, the immunogenicity and effectiveness of varicella vaccine, and lastly, choosing the recommendation between 1 and 2 dose regimen. Varicella, also known as chickenpox, is an acute infectious disease caused by the varicella zoster virus. VZV is a DNA virus that is a member of the herpes virus group. Varicella is characterized by mild fever, vesicles, and itching, and it can lead to serious complications such as secondary bacterial infection, pneumonia, encephalitis, hepatitis, and Reye syndrome. It is highly contagious with a 90% secondary attack rate within families. After the primary infection, VZV stays in the sensory nerve ganglia as a latent infection. Reactivation of latent infection causes herpes zoster. The very left photo is the typical varicella in children showing multiple vesicles. But it can be very severe in neonates who are born from non-immune mothers. And in immunocompromised cases, progressive varicella can be fatal. Before the introduction of varicella vaccine, the disease burden in the United States was significant, with around 4 million cases, 11,000 to 19,000 hospitalizations, and 100 to 150 deaths annually. The greatest disease burden was in children, with over 90 cases, and 70% of hospitalizations and 50% of deaths occurring in this age group. After introduction of varicella vaccine in 1995 in the US, the number and rate of annual varicella-related hospitalization declined. Overall decline in hospitalization was 88%, and by age, the decline rate was high in children and adolescents. Most people who died from varicella were completely healthy before they got the disease, without known risk factors for a severe case of varicella. After the introduction of varicella vaccine in the US, the fatal cases from varicella have declined dramatically. Active immunization is an appropriate, important preventive intervention for varicella. The varicella vaccine is a live attenuated vaccine. The OCA varicella vaccine was first developed in 1974 in Japan. Currently, the licensed varicella vaccines are used as the monovalent varicella vaccine and the tetravalent vaccine MMRV. As of the first half of 2021, 44 countries have introduced the varicella vaccine as a routine vaccination for infants. However, the vaccination schedules vary by countries. In some countries, use a single dose, which is indicated in blue, in Korea as well, whereas other countries use a second dose shown in orange. Overall, 28 countries use a universal 2-dose varicella vaccine regimen for infants. Mandatory vaccinations are provided in all countries except Austria and Cyprus. The first dose vaccine schedule is recommended at 12 months of age and after, but the second dose is recommended at various ages, 4 to 6 years in most countries, and 3 months after from the first dose in some other countries. In the US, since the introduction of varicella vaccine and the vaccine coverage increases, the reduction of the varicella cases was shown in 2 surveillance sites, Antelope Valley and West Philadelphia. At the same time, there was a shift in peak age from 3 to 6 years in 1995 and to 8 to 11 years after the vaccine introduction in 2004. So the good news is the prevention of varicella and varicella-related complication when the vaccine coverage gets higher. But the problem faced after the use of one dose of varicella vaccine in the US was the breakthrough infection, which means more varicella cases in the vaccine recipients than in the unvaccinated children, although the vaccine coverage rate is almost 90%. And these breakthrough cases are likely to occur as outbreaks in schools, so the people do not trust the vaccine effect. So breakthrough varicella, breakthrough infection, and vaccine failure remain important issues. Breakthrough varicella refers to wild-type virus that occurs more than 42 days after vaccination. So vaccine failure can be primary or secondary. Primary vaccine failure occurs when there is no effect in the first place, while secondary vaccine failure occurs when immunity wanes over several years, leading to gradual loss of antibodies. For the varicella vaccine, both primary and secondary vaccine failure are not mutually exclusive, meaning both contribute to breakthrough varicella. This slide from the study in the United States shows that immunogenicity measured by pharma antibody was about 80% to 85% in the children who received one-dose varicella vaccines. So 15 to 20% of the vaccine recipient might have varicella due to primary vaccine failure. In contrast, as shown in this graph, as the time goes by following the vaccination, more breakthrough cases tended to occur, which strongly suggests secondary vaccine failure or waning antibody. This is the meta-analysis of vaccine effectiveness between 1 and 2 dose schedules. Post-Horizons studies of effectiveness demonstrated the effectiveness of one dose of varicella vaccine ranged 20 to 100%, which is really large range. In contrast, the 2-dose schedule of varicella vaccine showed the vaccine effectiveness ranged 84 to 98%. In this study, both 1 and 2 doses were nearly 100% effective in preventing severe disease. A retrospective study was carried out in more than 800,000 children born between 2001 and 2017 in eastern China, and it aimed to assess the vaccine efficacy of 1 dose and 2 dose schedules. Children vaccinated with 1 dose had a significantly higher percentage of varicella infections than children vaccinated with 2 doses. So compared to no vaccine, vaccine efficacy was 72% for 1 dose and 90% for 2 doses. Now, by comparing the incidence rate, the average incidence rate of breakthrough varicella was 8.5 per 1,000 person year for 1 dose and 2.2 per 1,000 person year for 2 doses, showing further reduction in incidence rate by 2-dose schedule. Now let me change my topic to varicella vaccine history in Korea. In Korea, varicella vaccine was introduced in 1988. Since the late 1980s, high-risk groups and some healthy children have been selectively vaccinated. Varicella vaccine has been included in the National Immunization Program since 2005, and current vaccine coverage rate is more than 97%. Our recommendation is 1 dose for infants between the ages of 12 to 18 months. For those who have not received any immunization before and are under the age of 13, they only require 1 dose of the vaccine. And for those ages 13 years and older, require 2 doses with 4 to 8 weeks interval. Now, NIP started in 2005, as I told you before in a previous slide. Health insurance review and assessment service data from the National Health Insurance Service showed the number of claims due to varicella, which is shown in blue color, did not decline actually for a while until 2011. And since 2011, the number of varicella-related claims, which is blue color, tended to decrease afterwards. The trends of the annual number of total varicella cases in Korea from 2010 and 2021, according to the new different data sources from the National Health Insurance and National Notifiable Disease Surveillance System. So this figure shows the data from the surveillance system in which only varicella cases notified by medical doctors. The seemingly increasing instance rate of varicella, which is shown in red in the surveillance system, is a result of increased awareness in doctors' reporting and responsibility for notifiable infectious diseases, rather than an actual increase in varicella. The analysis using the more recent claims data during 2010-2019 shows an very important and interesting data, which is an age shift phenomenon with a decreasing trend in the annual total number of varicella cases in Korea. The age group of the susceptible prevalence of varicella cases has continued to change during 2010-2019. In 2010, which is shown in very dark blue, varicella was most prevalent in children under 5 years of age. In 2014 and 19, blue and light blue and red, it was more prevalent in children in 5 to 9 years, which suggests age shift to older age. This is the study done by myself, which is a long time ago, for the seroconversion and pharma antibody titers following the immunization. Among the vaccinated infants, 83% was seropositive by pharma assay, which means 16% did not develop a protective level of antibodies after 1 dose of varicella vaccine. In addition, in this graph in your right, you can see the antibody level tend to decline over time following the vaccination, which suggests waning in immunity. This study aimed to evaluate the vaccine effectiveness of 1 dose universal varicella vaccination by timeline and also by severity of the disease in Korea. In this study, a birth cohort of year 2011 were included for the retrospective study that analyzed insurance claims data from 2011 and 2018, and the varicella vaccination record in the nationwide immunization registry. So the vaccine effectiveness of 1 dose was 86% during the first year, which is not bad following the vaccination, and 50% during the 6-year follow-up period since vaccination, resulting in 7% annual decrease of vaccine effectiveness, which is that shows that waning immunity and then duration of protection declines. Despite these challenges, varicella vaccine has made a significant impact on the epidemiology of disease. According to the WHO in 2003, Routine immunization in children can lead to significant reduction in mortality and severe morbidity, and sustained high coverage, which is about 85 to 90%, can even lead to a virtual disappearance of varicella. But however, in 2003, if only partial coverage is achieved, the epidemiology may shift, leading to an increase in the number of cases in older children and adults. But this WHO stance in 2003 is now changed in 2014, which states that receiving one dose can help to reduce mortality and severe morbidity. In addition, receiving 2 doses can provide much even greater protection by not only reducing the risk of serious illness or death, but also by helping to reduce the number of cases and outbreaks overall. So there are currently 4 different WHO pre-qualified varicella vaccine, and Sky varicella, made by Sky Bioscience in Korea, was pre-qualified in 2019 by WHO. In conclusion, varicella is a highly contagious disease caused by varicella zoster virus. Both primary and secondary vaccine failure are the causes of breakthrough varicella, and varicella vaccine recommendation highly varies because different level of vaccine impact has been noted. So 1 dose of vaccine is shown to reduce mortality and severe morbidity, and giving 2 doses of vaccine schedule, it can further reduce the mortality and severity, and also reduce actual case numbers and outbreaks overall. Sky varicella, which was clinically evaluated in multi-nations, it has been shown it is a safe and well-tolerated immunogenic varicella vaccine in children who aged 12 months to 12 years of age, and it acquired WHO pre-qualification certification. So this is what I prepared, and I'm going to stop here. Thank you very much for your attention.